factor deficiencies. Mutations on the X chromosome, as we hit this multiple times, the gene for factor 8 as well as a factor 9 are both located on the X chromosome. Both look the same clinically, so A and B look the same clinically. Up to 30% of patients with hemophilia can have a new mutation. So hemophilia and HIV, plasma pooled from thousands of donors. So 1985 was the first HIV antibody test implemented for screening of all blood donors. Hepatitis C was essentially removed from the blood supply in 1992. So people are still alive that may have had HIV from hemophilia, and because they received from blood products and possible hepatitis C. So in this time period, over 50% of hemophiliacs got HIV. This is before the testing. And over 90% got hepatitis C. Recombinant factors are made in the lab. They don't come from blood. They're recombinant DNA technology. They're binary cells from Chinese hamster ovary cells. So when you think about the medicine that we have, how it's global, meaning that we are getting pieces from different parts of the world and we're using to assimilate, to make drugs, to make treatment plans. So medicine is universal and it's also global. So we have to remember that. So this is recombinant factors. These are man-made products and they're bioengineered cells, extremely expensive. Okay, the average cost for recombinant therapy in the US is extremely high. So to treat a hemophiliac annually is about $300,000 per patient. Hemophilia treatments of chronic, fundamentals of the chronic treatments for hemophiliacs on demand, meaning they have their recombinant factors on demand or prophylaxis 2 to 3 times a week on demand if they need it right then. And there's even discussion, you can even see articles during times of COVID where these patients weren't able to get their medications right away, or they were stuck in extreme weather conditions such as hurricanes or in freezing environments where they could not get these medications delivered right away as they needed them. Hereditary bleeding disorders. Talked about hemophilia A and B. A is 10 times more common than hemophilia B. Hemophilia B is the absence of factor 9. Also called Christmas disease. Wasn't because it was discovered on Christmas. This is named after the first patient. A and B present identically to one another. The only way you tell the difference is by measuring the clotting factors. You'll have a prolonged PTT with a normal PT, and the PTT will correct with a mixing study. We're going to talk about what a mixing study is. Mixing study, continue discussion, determine to have deficiency versus an inhibitor, okay? If you have a deficiency, you mix 50-50, the patient will come back to normal. If the mixing study fails to correct, you're going to have you're inhibited, the inhibitor comes in and it's knocking out the normal clotting factors and you don't correct. Hemophilia A and B treatment, continued discussion, replacement of the underlying factor with factor concentrates. Some patients may develop inhibitor from autoantibodies against factor 8. Confirmed by measuring a Bethesda titer, which measures the strength of the inhibitor. All right, let's go to another unfair board review question. And then first we're going to go here to our question stem and to our answers. Which of the following is the most appropriate next step in management? We're having a lot of managements in these ones. So high dose corticosteroids, begin eculizumab immediately, administer ciprofloxacin, initiate aggressive support care and careful foods with electrolyte management and avoid antibiotics and anti-motility agents, urgent plasma exchange. So this is a 26-year-old female with no past medical history. She should be healthy, has 3 days of abdominal pain and bloody diarrhea after the state fair. Okay, going to the state fair, healthy person, and then all of a sudden gets abdominal pain and bloody diarrhea. Exam shows pallor, so they're pale, and mild edema. Labs, hemoglobin's low, 7.9. Platelets are low at 48%. Creatinine is 2.1, so it's elevated. LDH is okay. Haptoglobin is undetectable. So we have something breaking down. Peripheral smear shows 3+ schistocytes. Coombs test is negative, and stool PCR is positive for Shingles toxin 2. Shingles toxin 2. So what are we going to do? What would be our choices that we could do to get this patient better? Would be initiate aggressive supportive care with careful fluid and electrolyte management and avoid antibiotics and anti-motility agents. Okay, so basically we're giving them fluids, we're avoiding antibiotics, and we're avoiding anti-motility agents because we're worried about the Shingles toxin related to Hus. It's a GI infection with the Shingles toxin producing bacteria such as E. coli 0157 H7, 0157 H7. So we want to avoid the anti-motility. We don't want to keep this toxin in, and we want to avoid antibiotics at this time. So we want to initiate aggressive supportive care with careful fluid and electrolyte management, avoid antibiotics and anti-motility agents. So HUS can cause thrombotic microangiopathy due to the circulating Shingles toxin, and the treatment is supportive care. RBC transfusion is needed while avoiding antibiotics, which may increase the toxin release. So if you give antibiotics, it can increase the toxin release. You don't want to hold the toxins in, so you avoid the anti-motility agents. Eculizumab can be used for atypical HUS, and we'll talk about atypical HUS and with complement deregulation once we exclude the toxin, Shingles toxin-related HUS. Corticosteroids do not show improvement. So eculizumab could be a fair statement, but we're going to use that later. Just think about it is we want to use this later. It's expensive. So expensive we want to hold on to, so we want to do supportive care first. Plasma exchange is not going to be needed on this. And remember, we want to avoid antibiotics, so we would take this question out right here. So the eculizumab we'll take out because it's expensive, so we're not going to use that right away. And then we can initiate aggressive support therapy. Hemolytic uremic syndrome, HUS. Usually due to infectious diarrhea syndrome from E. coli 0157 H7 and other Shingles toxins. Hemoglobin usually less than 10. Negative Coombs test. Increased reticulocyte count. You're hoping that because you want to have replacement. You have increased serum lactate dehydrogenase, your LDH levels. You have decreased serum haptoglobin. You have fragmented erythrocytes because you're having a breakdown on a peripheral smear. You'll have helmet cells and schistocytes. Remember, treatment is going to be supportive care. Steroids are no benefit. Plasma exchange, no benefit. Remember, this is from a Shingles producing E. coli hemolytic uremic syndrome. All right, so here we're going through a clinical scenario, and then we're going to follow up with a multiple choice question related to this clinical scenario. So first, let's do the clinical scenario. Somebody coming in, and a 48-year-old female complaining of large bruises, headache, confusion, myalgias, and arthralgias. They have a low hemoglobin and low platelet. All right, now let's take in the multiple choice question. Which of the following is the most important initial management? So important initial management, okay? Intravenous immunoglobulin, high dose intravenous methylprednisolone alone, therapeutic plasma exchange and corticosteroids, platelet transfusion, rituximab monotherapy. So what is this question? A 34-year-old female presents with confusion, petechia, and acute renal dysfunction. Laboratory studies reveal a hemoglobin is low, 8.2, a platelet count of 18,000, elevated LDH. So when we see increased LDH, we know that we're having lysis, and we're knowing we have a decreased haptoglobin, we know that we're having lysis. And then we have schistocytes on peripheral smear. This confirms it. Our Adams 13 activity is less than 10. What are we gonna do? What are we gonna do? So think about this right here. So we want to do what? We're going to do a therapeutic plasma exchange and give corticosteroids. So what do we got going on? We did this briefly before. We discussed about TTP, which is acute thrombocytic thrombocytopenic purpura. We'll go more through this, which is a life-threatening microangioplastic anemia characterized by hemolytic anemia with severe thrombocytopenia and organ ischemia. We're going to have an Adams 13 deficiency. Rituximab may be used in refractory cases, but a plasma exchange and corticosteroids will be initial. We're going to basically purify the blood, and the plasma is separated. So what is a plasma exchange? Plasma exchange is, first of all, you need to have the patient's going to need to get a temporary HD catheter placed, unless for whatever reason they have an HD catheter in. And you're going to have to call, most places will be administered by a blood bank. Their blank comes in, and they have a machine. It looks like a little washing machine, and so they're going to wash out the blood. So you're going to have you're going to take the patient's plasma out, and then you're going to spin off the RBCs, and then you're going to put in new plasma. So you're washing the blood. You're purifying and you're removing the ingredients in the plasma that's causing this patient to have what? To have breakdown of her blood products, because we have decreased haptoglobin, increased schistocytes, and we have an elevated LDH. Okay, now let's talk about thrombocytopenic purpura, TTP, thrombocytopenic purpura, which is abnormal activation of platelets and endothelial cells with deposition of fibrin within the microvasculature and peripheral destruction of RBC and platelets. Must have the thrombocytopenia, of course, that's part of the definition of it, must have the thrombocytopenia and microangiopathic hemolytic anemia without malignant hypertensive scleroderma renal crisis. So those would be another definition. Must also have, can also have fever, acute renal failure, and neurological symptoms, along with the thrombocytopenia. Most common cause is due to deficiency in Adams 13. What does Adams 13 do? It is a high molecular weight multimer. It cleaves the high molecular weight multimer of van Willebrand's factor. The multimer binds to the masses of platelets and causes the vascular occlusion and thrombocytopenia. The pentad for TTP, we love this because this is put on boards, and we'll talk about how this is wrong. Thrombocytopenia, platelet count usually less than 30,000. Microangiopathic hemolytic anemia, we talked about these are the two important things. Then the rest of the pentad is neurological dysfunction. Just think of those platelets getting clotted in the brain, so the brain is not going to get the fuel that it needs because it's going to have blockage. You're also going to have renal dysfunction and fever. How many percentage of these patients present with the pentad? Between 5 to 10%. That's it. 5 to 10%. Let's continue our discussion on thrombocytopenic purpura. A plasmid score can be used. So usually we want to have this platelet count less than 30, as we keep saying. So we want to have evidence of microangiopathic hemolytic anemia. And schistocytes on the peripheral smear will show this. Elevated LDH, we keep saying this, increased indirect bilirubin, decreased haptoglobin, and a negative Coombs test. You can have normal or mildly abnormal coagulation studies, PT and PTT. Adams 13 activity less than 10% confirms the diagnosis, but treatment should not be delayed while awaiting results. Okay, so we'll talk about this plasmic score. Okay, so the reason why you would do a scoring is that the Adams 13, depending on your system, if you're not in a superstar hospital, this thing can take quite a few days or a week to come back. So meanwhile, you can't just leave this person untreated. You need to get where you're coming up with a plan of at least eliminating other diseases and then kind of figure out if you're going to treat or not. The plasmic score is a basic score. You can look this up in different calculators online, and it says there's no active malignancy, no history of solid organ or stem cell transplant, MCV less than 90, INR less than 1.5, creatinine less than 1.5. So this gives us a scoring system where we can say, do we want to pull the trigger for the plasma exchange right now or before the Adams 13? Is our score or our pretest probability prior to the Adams 13 arriving back, do we want to pull the trigger now? All right, another question, then this is our clinical scenario, and then we're going to go to a board question, board style review question. A 37-year-old male complains of easy bruising, bleeding when he brushes his teeth, with ecchymosis and low platelets. Okay, so let's take a look at this. So then we're going to our question. What is the appropriate initial management? What is the appropriate initial management in this patient? So appropriate initial management in this patient. Who is that going to be? So platelet transfusion, observation, corticosteroids, splenectomy, rituximab. Okay, so let's go to the question. Is a 34-year-old woman presents with petechia and mild mucosal bleeding. Her platelet count is 18,000. Hemoglobin, white blood count, and peripheral smear are normal? Interesting. She has no history of liver disease, recent infection, or medication use. What is the most important initial management in this patient? Okay, so she has petechia and mild mucosal bleeding. Otherwise, she's kind of doing okay. So what do you have? Corticosteroids. What do we have? What are we talking about? We're talking about immune thrombocytopenic purpura, ITP. Now, the boards will use these terms interchangeably. They know that you're used to saying ITP, so they're not going to use it. They're not going to call it that because they're going to try to get you to get nervous, so you make a mistake. You make a mistake, you fail the boards, and guess what? You got to pay to do the boards again. They make more money. Is that a conspiracy theory? Probably. Is it possible? Who knows? So immune thrombocytopenic purpura. So we're going to listen and we're going to work hard to avoid paying more money to them. So if we did a peripheral smear on this lady, we're going to show that she has large platelets and no schistocytes. Large places, so it's isolated new onset thrombocytopenia with normal hemoglobin and leukocyte counts. Now let's talk more about immune thrombocytopenic purpura. The treatment, treat symptomatic patients or asymptomatic patients with platelet counts less than 30,000. You can give prednisone of 1 milligram a kilogram with slow taper over several days, over weeks, or dexamethasone 40 milligrams daily for 4 days. 25% of these patients respond and never relapse, but those who do not respond consider IVIG. And you're going to use this for about 1 to 2 days. If that doesn't work, consider rituximab or azathioprine. And if that doesn't work, then you would consider surgery with a splenectomy. Right, another clinical scenario. This is a 63-year-old female with atrial fibrillation on a cardiac wards noted for low platelets. All right, so she's on a cardiac wards. She has atrial fibrillation. And she's been in the hospital for about 5 days. And so this is a vague question, not a fair question. So 63-year-old with atrial fibrillation on cardiac wards noted for low platelets. Well, she's been in the hospital for 5 days. Did she happen to get heparin? And we're looking at a question of does she have HIT, which is heparin-induced thrombocytopenia.